We move on to the next speaker, Dr. Sathyan Parthasarathy. He's going to talk on Glaucomatous visual fields interactive session.
Very good evening. Would you like to just stretch yourself? Already Ronnie has done it. Want to get up once and sit down? I think it still looks like everybody is asleep. Okay, I think concentrating for 2 hours on this is, for me, it is almost I slept off, and one more person to accompany me was the one last person. So thanks so much for falling asleep. That means the teachers are good enough. So just to proceed with that, I am still going to take you for another 15 minutes to sleep. So the visual fields is area in which a person can see at a given moment. I am just seeing you without moving my eyes. That's the visual fields I have. Each eye has its own field of vision. The direction of fixation without head or eye movement. So I am just staring at you. This is how the visual fields is looked at. All of us know this man, the gentleman, the turquoise. So it's a hill of vision in the sea of darkness. What does it mean? You keep hearing this whenever you go to the glaucoma meetings. You keep on hearing this thing. So the hill of vision means the macula has the highest sensitivity. You show the lowest brightness, the macula can still pick it up. So that is the hill of vision. And as you go to the periphery of the retina, the sensitivity of the retina becomes lesser. You have to give a much more stronger or brighter stimulus for it to appreciate. So as it goes to the periphery, the hill becomes lower and lower and it becomes flatter. So macula being the top and then this comes down. All right. So the spatial extent, for me, I used to remember like this: 50, nasal is 60, bottom is 70, and this is the widest area, you have 90. 50, 60, 70, and 90. So don't have to really look at all this too much. Just simple remembrance. And when you have both eyes seeing together, then your field of vision is much wider. Okay, there is a interconnection between right and left eye, so you have a little wider area of the field. Then you have the sensitivity. We keep talking about this sensitivity whenever we are doing the visual fields. So there is a different kind of stimulus is being given. There's a different kind of a brightness is there. So the brightness is called as the sensitivity. So it is assessed in the decibel values. When you have the 0 decibel value, that means that is the brightest light. When you have a 32 or 40, that means it is the light, very dim light is being projected. So that's how it is. But normally you have between 30 to 35 is the range where most of us can appreciate. 40, I can't appreciate 40, maybe some people, but that's how the study shows that maximum sensitivity appreciation can be at 40. So whenever you are doing the visual fields, what are the things that you look for? One is you identify the pathology. Sometimes it may not be glaucoma, you are dealing with something else. Then you have the status of the disease. That means you are trying to say that, okay, the patient has early damage, moderate, severe, or advanced disease. So, and it helps in follow-up to see whether the patient has a stable disease or the disease is progressing. Then, once you start treating the patient, of course, we are going to see again the progression to understand whether the treatment efficacy is okay or not. Then, of course, it can be used for other purposes like visual ability testing. But at least in Tamil Nadu, what we have is the doctor, whoever is there, or even the driving license people, they just sign it saying that your visual field is okay. The patient never comes to you for any testing. So, looking at the glaucomatous field, so this is the fundus. Just try to understand how the nerve fiber layer arrangement is. That is where you have to see where the defect is. So this is the nerve fiber layer arrangement in a retina and the optic nerve, how it is getting into. More the peripheral nerves, it comes on the disc in the periphery. The more closer to the disc goes center of the disc. You can see the bottom here, in this bottom, you can see that the periphery, 5, you see the 5 is in the periphery and you see the 1 in the center. So that's how the nerve fiber layer is arranged. So there are different parameters, examination parameters, And also, of course, you have other things that we need to just see that type of perimetry and what is the type of stimulus, test pattern strategy. Let's look at each one. When you're looking at the types of perimetry, you have the kinetic perimetry and the static perimetry. Most of us, we don't use the kinetic perimetry. Where do you really use the kinetic perimetry in your, I think most of your PGs, where do you use the kinetic perimetry in your hospital? Madam? Bedside evaluation, okay, that is a confrontation. Where do you really use the tangent screen? Somebody in the back? Tangent screen, where do you use? Where do you use the tangent screen? Usually, at least when we were studying, we used to use the tangent screen for neuro-ophthalmology fields. Okay, now I don't know how many of you are really using for the neuro-ophthalmology fields, but we can use the tangent screen for the neuro-ophthalmology field, but usually now it is all the static perimetry, which is much more easier to do and more reliable to do than the kinetic perimetry. Of course, we have the two important machines for the Oculus. Some of you may be having it and using it. Humphrey and Octopus are the ones which are in the market. So just to understand about the static and the kinetic perimetry, static perimetry's advantage is it is a kind of a gold standard and have a high precision in threshold values, assessing the threshold values, and it is fully automated. And the kinetic is just opposite to that, but it has a high spatial resolution and has a fast peripheral testing, provides information about the visual function. So these are some of the things that where it is used, both are used, but no more common for the kinetic is in the neuro-ophthalmology field, low vision, children, all those patients that we can use there. So next, looking at the stimulus or the spot size, we have different spot sizes to assess, but usually it is the spot size 3 at an angle of 0.43. That is a standard stimulus size. If you really look at the Humphreys or Octopus, all of them, they use it at the size 3. The other size which is commonly used is the size 5. Where the patient has a low vision, where he is not able to appreciate, then we use the size 5. I don't know why they have given all the sizes, but usually we use only the size 3 and the size 5 as a common ones. And you have the stimulus types. What are the stimulus types? You have a standard one, that is a white on white perimetry. Then you have flicker perimetry, pulsar, swab, that is a function specific perimetry, where it is used for the early detection of glaucoma. The pulsar and flicker most commonly are used in the octopus perimetry. If you go to the stall in biomedics, you have the octopus perimetry 600. You can ask them to just show you. The swab is been used again in both the the perimeters, octopus as well as the Humphreys. The short wavelength automated perimetry, that is a blue on yellow, the blue background with the yellow stimulus. So what has been detected? White on white is a standard perimetry where you have the moderate to severe disease. That's really useful. If you really want to pick up like ocular hypertensive, glaucoma suspects and early glaucomas, possibly you can look at using the pulsar or the flicker perimetry or the swab. But swab really takes much longer time. The patient becomes really very tired. So there are certain test parameters are recommended. I'll just focus only on the glaucoma. There's something called as a G pattern. G pattern is one of the tests which is commonly used in octopus perimetry. And if you look at the Humphreys, we use either a 24-2 as a standard one. Sometimes we use a 30-2, but we have to avoid the peripheral points. But usually we all use only the standard 24-2 or the 24-2C program in the Humphreys now with the recent updates. So looking at the test strategy, but now with the advancements in the perimetry, I'm not sure how much we use it. But when you're using the Humphreys, earlier we used to use this 4-1 bracketing when you have a full threshold test, but we don't use anymore full threshold or even a G dynamic, we use it, but this is how it is done. Initially the 4 decibel lowering and 4 decibel incremental, and to assess how much the patient is able to appreciate. And 2 decibel lowering, 2 decibel incremental. Same way the 1 decibel lowering and the incremental. That's how the bracketing is done. And that is how many number of points for 1, 2, and 4. That's how it is. So the standard pattern in glaucoma care is the G pattern. The G pattern in octopus just follows the nerve fiber layer arrangement. That's why the G pattern is very popular. And if you really look at the 24-2C pattern in the Humphreys, it is also just following it almost closer to that. Uh, so this is very significant. If you don't have it on the nerve fiber layer arrangement, then you may just pick up some defects. So that's why the Humphrey is also changing its patterns. And of course, there are other alternative patterns which how many test locations. You have 32, you have 32-2 with the 76 locations and the 24-2 with the 54 locations. But the 30 G pattern is 30 degrees with the 59 points are the ones which are tested. The central areas are also focused more so that we don't miss out anything. The papillary macular bundle area also is picked up very well. Then, of course, these are the other test patterns other than the G pattern. Macular function also we can look at, that is the 10-2 program. Even in early glaucomas, we do the macular function or the 10-2 program so that we can pick up the early glaucomas. It's not like you would do it only in the advanced glaucomas. Sometimes you have the question on that. So this is how the octopus perimetry will look like, the 7-in-1 printout. I'll just discuss you a little later. And most of the time we keep talking about this age compared data. If you don't have the age compared data, then whatever you are seeing is not correct. So that's why when you are entering the age, make sure that the age has to be entered properly. Sometimes we have the confusion in the either in the US or in the Europe. What they do is they put the month and then they put the date and then the year. So there is always some amount of confusion, but that doesn't matter. But the year has to be mentioned properly. The few months plus or minus doesn't matter, but then this is another thing which is very crucial called as a defect curve or the baby curve. Is one of the wonderful persons. The baby we have, I have met him in person. He is a scientist, physician. He is not a doctor. So what they really do is, this is, you see here, how it is drawn is, it is taken from the comparison. You have defects, lot of areas are defective. So the lowest defect, that is a plus, that is less than 5 decibel loss, it is presented here, and then slowly as it progresses, you have the highest loss. This is like more than 30 decibel loss, it is projected here. So it starts from left to right, this is the normal range. If it is like this, then you'll have to see how it is the defect curve is drawn. So this defect curve will give us a lot of information on whether it is normal, borderline, or diffuse. And with that information, we can pick up what kind of a problem the patient has. Whether the patient has a local defect or patient has a diffuse loss, everything can be taken up. So something called as a cluster analysis, how the cluster has been taken. So this is the cluster graph. You see what all the area, points are defective. If it is closer to the 10 degrees, then you have to start the treatment much more aggressive. And the follow-up patient shows more cluster damages, more closer to the macula, something like this, then you have to augment your treatment. So this is the cluster analysis, and you have the polar analysis. It is actually extrapolation. This is a structural damage. It's not the functional damage which is presented here. Longer the lines, more the damage in the RNFL. So that is the structural damage. It is a. Then you have the global indices. So I will not discuss each one here, but what is important is, just let me, I think we have less time, you have a few more minutes. I'll just go through this. It's not moving. I'll just show you the difference between the Humphreys and the octopus, and then we'll stop it. So this is the progression analysis. We need to understand there's a software which is given in the octopus that we have to use it. So the software will give the trend analysis over a period of time, how much the damage has happened, And this is the complete progression analysis chart to show that how much is the diffuse loss, how much is the local loss, how much is the square root of loss variance, and how much it is every year on year, how much it is increasing. That is called as the slope. By looking at this, we can really understand whether the patient is progressing or not. But this is something interesting again. This is done with the octopus, different octopus machine. This is done with a different octopus machine. You can do with a different octopus machine, but then again you can see the progression. It will give you a different one is triangle, one will be square, so we can understand which machine has been done, and then we can look at the progression also. So if we have some time, then we can discuss how we can, like octopus and Humphreys, but
I
I'll
think you
just
can
stop
do.
it here. We'll have the questions at least for 5 minutes. We have only 5 minutes.
Yeah, we can.
No,
Yeah,
we
we'll have
started
questions
5
for
minutes
5
late,
minutes.
so we can have any questions you have, please. If you don't ask questions, that means you have understood everything, then we will ask you questions.
Sir, I think you should ask, sir. Yeah.
It's for the postgraduates. If you don't ask doubts, that means all the doubts have been cleared. So we will ask you questions to answer.
The first question will be to Dr. Ambika. She's one of the senior most ophthalmologists from Netherlands, and she's one of the wonderful persons in neuro-ophthalmology. So you have to have one question for her.
I think I
She has
spoke on
promised to take
localizing
you
the
around in the
lesions.
cruise. So ask one question.
You know my topic. It was localizing the lesions. Made simple.
Anyone has any question?
Anyone? Can the eye movements be used to record the lesion in central nervous system looking at the eye movements only? Yes.
Sir, you can
Yes.
probably ask somebody who can point out with you the first row, second row, something like that, sir.
Anyone? Answering question is easy.
On to the left side.
No, they're all getting. You're getting.
They're all tired, sir.
Tired, I think. They have understood everything so much that
It goes without saying.
Okay, I will ask Ambika. See, you presented that in chiasmal syndrome, depth perception can be affected.
Yep.
The problem is the two hemispheres interconnection is in the posterior callosal fibers. That's where the stereopsis happens. Whereas chiasmal syndrome happens more anteriorly.
See, actually, it is not only the stereopsis part which is being disturbed. If you could see in a bitemporal hemianopia, we have something called post-fixational blindness.
Yes.
So when a post-fixational blindness do happen, a patient who is not, I mean, he can see at a point, but he can't see beyond that.
Beyond the point.
So that when a patient is coming down on a steps or when they do look down, so they can look at that, but beyond that they will not be able to see clearly. So that is one of the most common complaints what a patient do come up with. So here it's not the stereopsis which plays too much, or rather there can be a hemifield slide phenomena type of thing.
Yes.
If there is a pre-existing phoria, that patient will have the two fields colliding to each other,
Colliding and moving like
moving
that.
here, which will give you almost like a picture which affects your depth perception too much. That's
I
one of the
suppose-
features of chiasmal syndrome.
I suppose the global stereopsis compared to the other stereopsis,
True.
they
Yeah.
may be in different parts of the callosal
Parts.
fibers. Because brain is very complex to understand. But it is amenable to understanding also if you go logically.
True.
Sir, thank you, sir, because
Thank you very much.
GBM is going to start. I think all of them.
Oh,
have to
okay.
go.
Oh,
They will
So thank you
Thank
so
you so
much
much.
for all the speakers, and thanks for chatting, sir.
Thank you.
thank you so much.
Thank you very
All the
much.
speakers, thank you so much for. Yeah, madam. I'm so happy that at least one person is asking a question.
Come to
Ask
the
a
mic.
question which we can answer, okay?
Shoot your speaker.
Basically, there was a question related to 24-2C. I'm just a first year resident, but they asked us that there is a neuro-ophthalmic field effect in which there's an upcoming field in which 24-2C can be used as a.
In neuro-ophthalmology, you are asking, you want to answer that? Dr.
No,
Ambika?
I haven't seen. What
Ronnie,
field
you are a,
24.
Ronnie, you are a
Ronnie, you have
Humphrey.
seen anything?
Ronnie,
See?
you are a Humphrey user. Would you like to answer that?
Yeah.
Use the mic, please, Ronnie. Or come here.
The 24-2C essentially has 9 additional points in the central area. So you get much more information from the central 10 degrees than the traditional 24-2. I'm not sure what specifically in neuro-ophthalmology they were looking at, unless it's something, a lesion which is, let's say, a centrocecal scrotum or something like that. I don't know.
Because I think most of the central scotomas we do pick up in the like 24-2 itself. And a simple Amsler will also be giving the same amount of value of 20-degree field loss. But I don't know this extra 9 points, what extra it's going to give, unless you differentiate.
What was the entire question?
In general, if you are going to ask whether
Yeah.
24-2 program, C program, it can be done. Only thing in this is the central 10 degrees. You have a number of additional points are there. Otherwise, it is same as like 24-2.
What was the specific question?
The modality in the edge, so I can't remember the exact question, but it was like there's a new modality which has an addition for neuro-ophthalmic radials, which has an additional advantage over 24-2 and 10-2. If you combine this, there is a 10-2, 24-2 C region, C field, which helps you in a better analysis of a neuro-ophthalmic radial.
I think I should be able to answer this. See, the gap between 2 points in 24-2 and 30-2 is 6 degrees. Whereas in 10-2 it is 2 degrees. And in 24-C it is 2 degrees in the central portion and 6 degrees in the peripheral. So you can pick up smaller lesions in 24-2C. Same as 10-2.
Yeah.
But at the same time, you can see little peripheral lesions as well. The 10-2 cannot see at the mid peripheral lesions, which are better seen, which will be seen in 24-30. So you can not only pick up mid peripheral lesions, you can pick up the smaller lesions.
So that's probably true, but the thing is that for neuro-ophthalmology, one of the issues with 24-2C is that it does not actually have symmetric distribution of the additional points.
Yeah.
So that is a downside when you're looking at a neuro-ophthalmic defect, which may have, because
Usually it follows the vertical line.
Follow
so
the
this is a sort of,
vertical.
it's almost, because there are 9 points, they're not equally distributed all around. So you just Google it, you'll see the distribution, then you'll know what we are talking about.
Thank
Okay,
you.
thank you very much, all of